Limbs for life. Save the limbs because limbs are life. This is objective of this program. Measures of diabetic foot examination. Steps of diabetic foot examination. Practical assessment, which consists of history, taking examination and investigation. Classification of diabetic foot into neuropathic and neuroischemic foot. Staging the foot. The 6 specific stages in the natural history of diabetic foot are: stage 1 normal foot, stage 2 high risk foot, stage 3 ulcerated foot, stage 4 infected foot, or stage 5 necrotic foot, or stage 6 unsalvageable foot. Management plan for each stage. सबसे पहले examination. The feet should be grasped gently, firmly, and poking. Prodding and tickling should be avoided. The toes should be separated gently. If they are pulled apart violently, the skin between toes may submit. The examination should be performed systematically. It consists of five parts: inspection, palpation, neurological assessment, footwear assessment, general examination. First step is inspection. The feet should be fully examined in a systematic fashion. First the right and then the left, including dorsum, sole, medial border, lateral border, back of the heel, malleoli, and interdigital areas with a full assessment of the following: skin, corns and callus, nails, edema, deformity, limited joint mobility, color, and necrosis. What is pes cavus or high arch feet? Normally, the dorsum of foot is formed due to medial longitudinal arch, which extends between first metatarsal head and calcaneus. When it is abnormally high, the deformity is called pes cavus. Humerto, the humerto is lax or rigid deformity characterized by buckling of toe. The toe takes on the configuration of swan necks in people with diabetic neuropathy. Hammer toes are commonly caused by weakness of small intrinsic muscles of feet. Claw toes are similar to hammer toes but with more buckling and greater deformity. There is fixed flexion deformity at the interphalangeal joint associated with callus and ulceration of apex and dorsal aspect of the interphalangeal joint. Hallux valgus. Hallux valgus is deformity of first metatarsophalangeal joint with lateral deviation of hallux and medial prominence on the margin of foot, as you seen in the figure. And then Charcot foot is the rare serious complication that affects person with peripheral neuropathy, especially with those with diabetes mellitus. Charcot affect the bone, joint, and soft tissue of the foot or ankle. The bone becomes weak and can break, and joints in the foot or ankle can dislocate. This is a very serious complication of diabetic patient. And who gets Charcot? Charcot foot develops in person who have peripheral neuropathy. This is the condition where nerves in the lower leg and feet have been damaged due to uncontrolled diabetes mellitus. The damage causes a loss of sensation in the feet. If left untreated, what will be happen? If not caught in its earlier stage, the joint in the foot collapse and foot eventually become deformed. A deformed foot can cause pressure sores to develop in the foot or ankle. An open wound with foot deformity can lead to an infection and even amputation. Know what is the pathophysiology or what happened in charcot foot? Bone and joint damage in tarso-metatarsal joint and mid-tarsal joint lead to two classical deformity. The rocker bottom deformity, in which there is displacement and subluxation of tarsus downward, and the medial convexity, which result from the displacement of talonavicular joint, are from tarso-metatarsal dislocation. Both are often with the bony prominence, which is very prone to ulceration, and healing is notoriously difficult, as shown in figure. And then charcot osteoarthropathy. This is an acute osteoarthropathy with bone and joint destruction that occur in the neuropathic foot. That is already mentioned in is the complication of the uncontrolled diabetes mellitus. It is commonly present in midfoot, but also occurs in forefoot and hindfoot. The prognosis for the hindfoot is much more serious, with the high risk of instability of the ankle and the necessity for the major amputation. What is the clinical presentation of the Charcot osteoarthropathy? Patients who develop Charcot osteoarthropathy usually have evidence of peripheral neuropathy, autonomic neuropathy, and a good blood supply to the lower limb. Patient may have symptoms of autonomic neuropathy such as gastroparesis, diabetic diarrhea, gustatory sweating, or postural hypotension, that are all the complications of the uncontrolled diabetes. Diabetic patients with renal transplant have a high risk of Charcot osteoarthropathy, and it is divided into two phases. Charcot osteoarthropathy can be divided into two phases: acute active phase and chronic stable inactive phase. Acute and active phase is characterized by unilateral erythema and edema, as shown in figure. The foot is at least 2 degrees Celsius hotter than the contralateral foot, and the difference may be as greater as 10 degrees centigrade. This may be measured with infrared skin thermometer. The hallmark deformity associated with the condition is midfoot collapse, described as rocker bottom foot. Although the condition appear in other joints and with other presentation, pain or discomfort may be feature of this disorder at the active phase, but the level of pain and significantly diminished when compared with the individual with normal sensation and equivalent degrees of injury. And the patient presents and the patient, when present with the acute pain and swelling of the foot and having a diabetes mellitus, what will be the differential diagnosis of the acute osteoarthropathy case study? A patient of 65-year-old male with the type 2 diabetes mellitus of 21 years duration developed a hot red swollen left foot after tripping in the street. On examination of the foot was hot swollen, particularly over the lateral aspect of the ankle. However, pulses were not portable and the pressure index was 0.6. X-ray was normal. The differential diagnosis was an acute Charcot osteoarthropathy or soft tissue injury. Charcot osteopathy was thought to be less likely in the view of its in the view of the moderate ischemia. However, it could not be excluded. The foot was put in a cast until the MDP bone scan was performed. This showed a difficult diffuse uptake around the left ankle but no focal body change, including a soft tissue injury. The patient was mobilized without a cast and swelling gradually resolved. And second case, a 45-year-old woman with type 2 diabetes mellitus of 10 years duration presented with dead cold, painful swallow, first hope. X-ray shows a fracture line in the subchondral area adjacent to interphalangeal joint with erosion, as shown in figure. There was no history of trauma. She was on hemodialysis. Serum urate was raised, but it is likely that this was associated with her impaired renal function. The patient was treated in a cast, and the swelling and discomfort resolved over subsequent 3 months. The initial manifestation of Charcot foot are frequently mild in nature but can become much more pronounced with unperceived repetitive trauma. Components of neurological, vascular, musculoskeletal, and radiographic abnormalities. There have been no reported cases of Charcot neuropathy developing in the absence of neuropathy. Swollen, warm, and often erythematous foot with only mild to moderate, modest pain or discomfort. Acute local inflammation is often the earliest sign of the underlying bone and joint injury. The diagnosis of the Charcot foot is mainly on clinically, but can be helped with imaging. First imaging is X-ray. Radiograph are the primary initial imaging method for evaluation of the foot in diabetic patient. Easily available and inexpensive. They provide information on bone structure, alignment, and the mineralization. X-ray may be normal or show subtle fracture and dislocation, or later show more overt fractures and subluxation. In later stages, the calcaneal inclination angle is reduced and the tail first metatarsal angle is broken. And the second investigation, as you know, is MRI. Also allows the detection of subtle changes in the early stages of active CN with X-ray could still be normal. And then is bone mineral density may be useful in the patient with diabetes to assess the onset of the Charcot neuropathy as well as fracture risk. Bone mineral density can also be assessed using the dual image X-ray anthropometry with calcaneal and ultrasound. Diagnostic recommendation of active Charcot foot, as I said earlier. The diagnosis of the active Charcot foot is primarily based on the history and clinical findings, but should be confirmed by imaging. Inflammation plays a key role in pathophysiology of the Charcot foot and is the earliest clinical finding. The occurrence of acute foot or ankle fracture or dislocation in neuropathic individual is considered active Charcot neuropathy because of the inflammatory process of the bone healing, even in the absence of deformity. X-ray should be initial imaging performed, and one should look for subtle fracture or subluxation if no obvious pathology is visible. MRI or nuclear imaging can confirm clinical suspicion in the presence of normal appearing radiograph. No an algorithm summarizing the approaches to the Charcot foot. First, clinically assessment of the Charcot foot. X-ray हम कर रहे हैं imaging. If X-ray finding is positive, then we go for offloading If the treatment or offloading approaches is effective, then after consolidation, prescription and footwear and follow. If offloading is ineffective, consider surgical management, and then after consolidation, offloading and close follow. X-ray, if X-ray finding is negative, then we go for MRI or other nuclear imaging. If it is negative, then childhood foot is not likely. Or if MRI finding is osteomyelitis, then treat the osteomyelitis. No, there is a question here. Uh, Application of mechanical principle to biological system, biomechanics. Kinetic angular movement represent as torque. Dash is the sequence of movement during locomotion, fuel cycle. Thank you.